Okay. Hi, everyone. Welcome back. I hope you enjoyed the lunch break. We had such wonderful presentations this morning, and I'm looking forward to our lineup of talks this afternoon. If you're just now joining us, I'm Dr. Jasper Estabillo, the Director of Training for the UCLA Tarjan Center. And it's my pleasure to introduce our next speaker, Tarjan Center Director of Justice, Equity, Diversity, and Inclusion, Dr. Brandon Ito. By way of background, Dr. Ito completed his undergraduate degree from UC San Diego, his master's degree in public health at Harvard University, and medical school at the UC Irvine School of Medicine. Dr. Ito completed his adult psychiatry training at UC San Francisco and his child and adolescent psychiatry fellowship at NYU, where he served as chief fellow. Dr. Ito is passionate about medical education, LGBTQ mental health, and reducing healthcare disparities in vulnerable populations. Dr. Ito is a designated UCLA Health LGBTQ champion, attending psychiatrist in the UCLA Child and Adolescent Neurodevelopmental Clinic, inpatient hospitalist on the Child and Adolescent and Eating Disorder units, and UCLA Gender Health Program provider. His educational roles include Psychiatry Core Clerkship Chair and Educator for Excellence at the David Geffen School of Medicine, co-director of the Klingenstein Third Generation Foundation Medical Student Program and Psychiatry Interest Group Supervisor. And as previously mentioned, Dr. Ito is the Director of Justice, Equity, Diversity, and Inclusion at the UCLA Tarjan Center. Let's give Dr. Ito a warm welcome as he presents on intersectional identities and neurodiversity. All right, I'll hand things over to you, Brandon.
Thank you so much. I'm going to share my screen, hopefully. Okay, hopefully everybody can see my screen. It's a pleasure to be here to talk about somewhat of a complicated but very important topic, which is intersectionality and how our identities can impact the way that we are seen, the way that we are treated, and the way that we behave in the world around us. I'll start off with some disclosures. So I do not have any financial disclosures. I identify as neurotypical, able-bodied, cisgender, and male or a man. This is important because I want to be able to appreciate and identify that some of the topics that we will be discussing today are about communities or populations in which I don't directly belong. So my perspective may be different than others. Throughout this talk, I will be using person-first language as is the style in academic medicine. It is also to acknowledge that other individuals would prefer to be called or referred to differently. So to go through our learning objectives, the first thing we're going to do is define this vague term of intersectionality. The purpose being to be able to describe the literature on how intersectionality and how intersectional disparities can be created and exacerbated among neurodivergent youth, and also to analyze ways that intersectionality can impact both the research as well as the data and as well as the clinical care that we provide individuals with autism spectrum disorder. So I want to start off by defining intersectionality. And while I do this, I hope that each of you in the audience would be able to reflect on your own personal identities. It may be related to gender, it may be related to sexual orientation, race, ability, religion, education, age, and to think about how important each of these identities are to you. Intersectionality recognizes that we are made up of a number, somewhat infinite number of identities, and each of our identities interact and intersect with one another. The concept of intersectionality, or the theory of intersectionality, states that this interaction between our different identities can sometimes create new identities that are more than just the sum of the parts. So for example, I am not just male, I am not just able-bodied, and I'm not just Asian, but sometimes do these individual identities interact with one another to create a whole new identity of its own. And we'll go through some examples. The reason I feel like this process or viewing things through an intersectional lens is really critical, especially in the work that we do, is because it gives us the ability to highlight both areas of power and oppression. So where people are being marginalized and where people are being privileged in the care that we deliver. The other reason is because it helps to make invisible disparities visible. I'm going to use the words of Professor Kimberly Crenshaw, who developed the theory of intersectionality, in which she states that intersectionality is not primarily about identity. So it is not just that I have 5 oppressed identities or 5 vulnerable identities, and that makes me more disabled than somebody who has less than that. But it's about the structures that make certain identities the vehicle, the consequences of, and the vehicle for vulnerability. So again, we'll go through examples to hopefully make this concept a little bit more clear. Okay. So a general example that I will use is this is a paper in JAMA Psychiatry in which it looked at the prevalence of suicidal ideation, plans, and attempts based on different identities. So gender identities, sexual orientation, race and ethnicity, and also rurality or where people lived. And what we can see if we zoom in on the results, and hopefully people can see my pen or my cursor. If we look at the results, it shows that, let me see, sorry, let me make sure my pointer. Okay, if we look at the results, and we look at the suicide attempt rate or suicidal ideation, suicide attempt rate among heterosexual Black or Hispanic men in a large metropolitan county, and we look at the same for women in a large metropolitan county, we see that the prevalence is pretty low, or 0.5%. If we stopped there and stopped looking at this data based on different identities, we would run the risk of missing out that among bisexual Black men and Black women, this number or this risk of suicide attempts is much, much higher than the group as a whole. Similarly, if we look at the identities or the suicide attempt rate among heterosexual Black men and women in a rural or non-metropolitan county, we can see that if we just took this data as a whole, we would be missing huge populations of individuals who identify as bisexual, Black, Hispanic men and women who have much, much higher risks of lifetime suicide attempts. So now that we've introduced the concept, I want to talk about why this is important. What are the effects of these intersectional identities and how do they create or how do they increase health disparities that we see in our data? Okay. So we'll start off with racial disparities. So among individuals or among groups who have diagnoses of autism spectrum disorder, we know that there are a lot of racial disparities within the diagnostic timeline. So individuals who are from minority groups tend to have an ASD diagnosis that is diagnosed later in life. Some of the time to diagnosis is affected by access to care, social economic status, parent knowledge and report, and also the IQ of the individual being assessed. Either way, we know that on average, white children receive a diagnosis of autism at the average age of 6.3 years, compared with 7.9 years for Black children. You can think of as a group how children might benefit or how children might be put behind if their treatment, diagnosis, and understanding was delayed by a year and a half. When we look at intersectional disparities or healthcare disparities based on gender, we know from the data that males are more likely to be diagnosed in ASD. This may be related to a intersectional identity. It may be related to the underlying phenotype or demonstration of symptoms. But we also know that females are more likely to be missed and diagnosed later in life. If we take a deeper dive and look at disparities in service use among children with autism, We again see that racial and ethnic minority groups and children from low-income families have less access to acute care, specialized services, educational services, and community services compared with higher income and white families. So, and again, the reason why this is important is because as we think about the services that we provide to the community, that we provide to individuals and our families, it is to ask, are all families receiving the same services and the same level of care? When we look at further data on intersectional health disparities, and we consider both race and gender when discussing groups of individuals with autism spectrum disorder, we know that there is earlier diagnosis among minority groups in some population studies, but this is primarily individuals who have intellectual disability, so autism and intellectual disability. Among minority groups without intellectual disability, we see those racial disparities that we discussed earlier. We know that if we take a deeper dive and look at both race and gender of different individuals diagnosed with autism spectrum disorder, we see that there's even greater delays among Black and Asian females with autism than among the larger group. And again, if we look at intersectional identities and we look at different groups, so low English proficiency Latino families. Low English Latino families report more barriers to knowledge about the diagnosis of autism, more stress in the process, less trust in the system and providers, and they also report less therapy hours and more unmet needs than individuals who are not either low English or Latino ethnic groups. When we look at data based on healthcare providers who serve low English proficiency Latino families report that there's less screening availability and knowledge within this population. Primary care doctors report more difficulty in assessing for autism in Latino families. And again, less Spanish-speaking services that are available to them. If we look just beyond diagnoses and disparities in care, and we look at disparities in our research data, this was a study that was done by Watkins, Zimmerman, and Poling in 2014, so it was a while back. But among the 1,400 articles that they assessed, greater than 8% of the articles did not report any gender in their treatment outcomes or their population studies. In the 1,400 articles that the authors looked at, 86% of all the participants in the research studies that they could find were male. And even if we take the 1-to-4 or the 4-to-1 ratio as being our standard, our baseline of males to females, 86% of participants being male is way above that number. Another data point that I found striking was that when they looked at studies on interventions, or when they looked at studies of autism in females, 0.5% or 0.5% of the studies that they found were among female-only population groups. So again, when thinking about these intersectional identities, it is a question for me about who do we have data about and which data are we missing in our research? In a similar study by West, Travers, and Kemper, they looked at disparities in research on looking at specifically at evidence-based practices. So if they took articles, individuals with autism spectrum disorder, and they narrowed it down to articles that talked about evidence-based practices, therapies, medications, etc. Only 18% of these studies reported any race and ethnicity. Of those that did report race and ethnicity, 63.5% of the individuals in the studies were white, 21% were multiracial, with the other percentages being much lower. As we know from our general population census, This is not the representative breakdown of our general population, and specifically not within Los Angeles. So again, asking the question about who do we have information, data, and evidence-based interventions on, and which families or communities are we missing? The risk of not looking or not using an intersectional lens to analyze the data, to analyze our services and what we are providing is that one side effect is that it creates a representation of what an individual with autism spectrum disorder would look like. So if we base it on the studies, a predominant amount of the studies looked at boys or men who were white. And then we can indirectly see this reflected in our popular media for a number of different reasons. But it only enhances the risk of missing individuals or missing communities that are not receiving those services. Okay. Another example that Professor Crenshaw uses when emphasizing this point is in 2019, when we think about media representations or news representations of individuals who are killed by police, a lot of the focus was on Black men who were killed by police. They were the central focus of a lot of protests, a lot of attention, a lot of criticism and thought around policing. And in this way, it neglected all of the Black women that year who were also killed by police, who did not get as much attention, representation, and advocacy on their behalf. Okay. So let's use another case example of individuals who are diagnosed with autism within a population of trans and non-binary youth. If you were at the Tarjan Forum last year, you may have heard me talk about different statistics that show that while the general prevalence of autism spectrum disorder and gender dysphoria are generally low, the pooled prevalence among people with both autism and a diagnosis of gender dysphoria is higher than would be expected by the population numbers. So a pooled prevalence of about 11% of individuals. We know that in gender-referred youth or in youth who are presenting to our gender health clinics, the percentage of these youth who are diagnosed either with autism spectrum disorder or suspected of having autism spectrum disorder or diagnosis is very high. So again, near the pooled prevalence of 11 to 12%. In youth presenting with autism spectrum disorder, we know that from surveys and data is that these youth are 7.6 more times more likely to wish to be the opposite sex, or again, presenting with a more diverse gender identity. This is just another visual representation to show that among individuals, so males and females who have been diagnosed with autism, their self-reported gender identity tends to be more expansive and more fluid. So why is this important? Why is it important to know that individuals with autism have a broader range of sexual and gender identities than the general population? These are important intersectional details to take into account because we know the current environment that we live in across the country is highly focused and highly stigmatized against certain populations. So this is a map from the ACLU from earlier this year, which shows that there are 527 anti-LGBTQ bills that are currently in process across the United States. Among those anti-LGBTQ bills, there has also been a wave of legislation across the country banning gender-affirming care for trans and non-binary youth, either through proposed legislation or either through enacted legislation. And you can see many states here in the middle have enacted legislation banning gender-affirming youth. I will tell you that in these states, this represents about 1/3 of all trans youth in the country. So 1 in 3 trans-identified kids are living in a state where they are unable to access any gender-affirming care. So how does this overlap with autism? This overlaps with autism in a number of ways. So here's one example. This is an article from the National Review published several years ago before there was a lot of more attention and data looking at the overlap of these two intersectional identities, in which the article talks about autistic children pushed to become transgender. In this article, they state most of the youngsters undergoing the transformation are autistic, according to a teacher there who said vulnerable children with mental health problems were being tricked into believing they were the wrong sex. The consequence of not understanding this data is for example, this. So this is a news article from last year looking at a Georgia bill which restricted gender-affirming care for minors. In this bill, they used the fact that there is a higher rate of individuals with autism who identify as transgender as one of the reasons to say that this care should be banned because sorry, let me get this right. It should be banned because people with gender dysphoria also have autism or mental health conditions which impair their ability to understand or make decisions about their medical care. Okay. We know transgender individuals at baseline face a number of negative experiences, discrimination and harassment that already results in delays in treatment and care, avoidance of preventative care, which again puts people at high risk of negative health outcomes. Let's see. For those who identify as both trans and as having autism spectrum disorder, 1/3 of these youth report that they've had their gender identity questioned in a gender clinic because of their ASD diagnosis, or in the medical clinics due to their ASD diagnosis. So looking at what are the impacts, or what are the potential health impacts of these intersectional identities? So it is important to consider the many different identities and how they interact with each other, because we know that hate-related events or hate-related stigma based on somebody's identity overall have more negative mental health effects. So if somebody is targeted because of an identity, whether that be race, sexual orientation, or gender identity, we know that these hate-related events have more affect people more negatively than, say, a person who is randomly called a name that they don't identify with necessarily. We know that youth with autism who also identify as trans or non-binary are more likely to report online relationships. So we can think about how this impacts both socialization, also support around mental health. And it's important to consider that some individuals with multiple minoritized or stigmatized identities may be at risk for what is termed, quote, double jeopardy, meaning that individuals might face both stigma, harassment, prejudice because of their disability, in addition to their gender identity, in addition to their race, for example. So placing people at risk for experiencing multiple different types of stress. Okay. In looking at studies of youth who have been diagnosed with autism and also identify as trans, one of the common themes that have come out is that individuals sometimes have stress navigating the different identities and different communities and figuring out where they fit in within each individual group. I want to focus now and talk about what does the data say, or what is represented among these youth in the literature that we have for our youth, our gender diverse youth with autism. One of the prominent themes that has been discussed in the literature is the impact of neurodiversity in navigating their gender identity. So again, we talked about double jeopardy and the fact that people may face multiple minority stressors and have to deal with multiple kinds of harassment and prejudice. We also talked about isolation and how this can affect people's relationships and support. one of the key points of data that came out of this literature, that I've seen come out of the literature, is that for youth who have gender health needs and have needs related to their diagnosis of autism, they often differ from families in terms of what is prioritized and what is the most important in care. So, for example, for families presenting for medical care, families often prioritize or focus on the mental health needs of for the diagnosis of autism, whereas youth presenting for care are often focused on their medical needs related to their gender, and think that their needs related to the diagnosis of autism is less important or less of a priority. Other general challenges which we can expect is that a lack of knowledgeable providers. So in medicine, our fields tend to get a little siloed. And so a lot of people who provide gender affirming care and may have a lot of expertise in the LGBTQ community don't necessarily have the same level of expertise in treating individuals with autism spectrum disorder, and vice versa. Individuals who work in clinics focused on um, neurodivergence and focusing on care for individuals and families with autism may not have a lot of deep understanding or a lot of experience working with trans and non-binary youth. There's additionally access and barriers to care. This deals with financial, insurance restrictions, finding knowledgeable providers again. And one of the big themes that has come out among literature focusing on these youth is that they really worry about not being listened to. And I think this is a theme that is very important, which is if individuals come in and say people have a thought or a poor understanding of what autism means and what it is, a lot of youth worry that their gender concerns will go completely unnoticed or unheard. So again, as a result of these two different intersectional identities, they may be at risk for receiving less care or less appropriate referrals. When we look at what the needs of the youth, some of the themes that have come out is that for individuals who are gender trans and gender non-binary who have autism, is that there's more of a vague awareness or understanding of what gender means and why it's so rigid. They're also worried about bias and harassment. So there might be discomfort expressing their gender, worries about gender being questioned, but also a confidence and hope in general for the future. So what we don't have currently in our literature is actually looking at a lot of the resilience or protective factors among trans and non-binary youth with autism, because there can be a lot of positives from being in two different communities, and that is also somewhat represented in the literature, that if you have strong community supports in multiple communities, so maybe the LGBTQ community and also a racial or ethnic community, and then a religious community, and then a family community, that these things can all be protective. All right, so in summary, what I hope to propose or I hope to put out there is that using an intersectional lens or thinking about how different identities interact and perhaps change a person's perspective, how they are viewed by the world, or what resources they are able to access can help us to identify some groups who are facing very unique or additional challenges compared to the broader population. We need research on intersectional identities because this further spotlights health disparities. So going back to, there may be some particular groups within groups that are hit particularly hard. And also the importance of more inclusive research in order to improve our care, including both, again, the protective factors, the joys and the benefits of having multiple and diverse identities. So I will pause there.
Hey, thank you so much, Dr. Ito, for that fantastic presentation. I know that I learned quite a bit, and I always do whenever you speak. We'll save some time at the end of this session for our audience to ask Dr. Ito questions. But in the meantime, I would like to introduce our community discussant, Josh Chou. All right. Hi, Josh. It's good to see you. Josh Chou is a graduate student in the UMass Boston Clinical Psychology doctoral program under the mentorship of Dr. Abby Eisenhower, and a graduate student researcher in the Noonan Foundation Smooth Sailing and Early Childhood Research Study. His research interests are centered around the socio-emotional cognition and interpersonal relationships of transitional age autistic youth. Prior to his graduate studies, he graduated from UCLA, where he earned a Bachelor of Science degree in psychobiology with double minors in disability studies and global health, and served as a clinical coordinator at the UCLA Peers Clinic under the mentorship of UCLA Tarjan Center Director, Dr. Elizabeth Lageson. So I'll hand things over to Josh for your reflections.
All right, let me quickly share my screen. All right, good afternoon, everybody. I'm excited to be here today to talk about unmasking intersectionality, specifically dissecting my lived experiences with my intersectional identities through the lens of privilege and oppression. So to give an overview of what I'll be talking about today, first I'll be unpacking my positionality within the intersectionality framework. Next, I'll be talking about my lived experiences of intersectional oppression, how I experienced an intersectional internalization of these oppressive forces, and also the cost of this oppression. Then I will also talk about liberation through understanding these intersectional identities as they are socially constructed. And finally, I'll give a few takeaways from this presentation. Okay, first off, I want to start by saying that we all have intersectional identities. I included this quote here by Dr. Rosemary Garland Thompson. It says, "The normate subject position emerges from the sum of the privileged characteristics that identify them as the unmarked human standard, so white, male, middle class, heterosexual, and non-disabled." And so, yeah, Dr. Rosemary Garland Thompson was one of my professors at UCLA and a disability advocate and a scholar. And she describes this normate, right? This is somebody who we think of as a default unmarked model of a person. This is somebody we often think is white, cisgender, male, heterosexual, non-disabled, so on and so forth. And we see this as the default. And all these other marginalized identities, we see them as add-ons to this default. And that is a myth. No matter if you're white or a person of color, no matter if you are not disabled or disabled, you have intersectional identities. So if everyone has intersectional identities, why am I here today, right? I'm here to bring to you one set of lived experiences from my marginalized identities that are often sidelined, they're overlooked, and they're overpowered. And because when we are privileged in a certain way, we don't see that we are privileged. We assume that, everybody just has it like we do, and that those people over there, those people who say they're not privileged, well, maybe they just didn't try hard enough, or maybe they just had bad luck. What we don't realize is that this system we all uphold is built to be against their favor, because then in this case, we would have to recognize that we play a part in this and that this is an uncomfortable process. But at the same time, it's a very necessary one. So yeah, now I'm going to talk a little bit about my positionality. And so I'll be talking about my privileged identities and my oppressed identities and how these things come together to shape the power that I have in navigating society. So on the left-hand side here, you can see my privileged identities. So privilege, it refers to the unearned advantages or rights that I receive just based on being part of a dominant or socially favored group. And I socialize as a cisgender man. I'm physically non-disabled. I come from a relatively privileged socioeconomic background, and I speak English and Mandarin Chinese, and those are the two of the most common spoken languages in the world. And so all these things come together to give me a certain level of access in the world, to shape the way my life has been, that led me to be able to speak on this platform today even. And on the other hand, on the right-hand side here, you can see you've also experienced some oppression through these identities. And so oppressed identities are those that are marginalized or they're disadvantaged in society because they're perceived as deviating from the dominant norms. So I identify as queer. I am neurodivergent. Racially, I am East Asian. Ethnically, I am Taiwanese. And I also happen to be an immigrant to this country. So these privileged and oppressed identities, they come together to shape the power I have, but they do not operate independently of each other, and they are actually intersectional and interdependent. So I want to note that these multiply oppressed and marginalized identities, their barriers don't just add up. These barriers, they actually pose, and the discrimination that comes with it, they actually increase exponentially when you have more of these marginalized identities. And so that's important to note. And not only just that, the barriers from these identities, they don't just all add up into one single identity where I experience them and have this one, uniform experience in one type of way. I actually experience oppression in very specific ways, even within some of these identity groups that I belong to. So, for example, let's look at the intersection between race and queerness here, right? So I often experience racism within the queer community where the beauty standard is often white and Eurocentric, and people actively exclude Asian people in their dating pool. Or they fetishize or objectify us because people play into the stereotype that Asian men are not seen as masculine. I also, at the same time, experience homophobia in Asian communities. Although I am fortunate enough to have supportive parents, there are many outside of my immediate family who have stigmatized my sexual orientation and the way I should portray myself in a masculine way to conform to what a man should be like, what an Asian man should be like. Growing up, I've had to overcome all these things on top of the remnants of how the public's reaction to the HIV/AIDS pandemic has demonized queer people and how this stigma is pervasive to this day, even in the Asian community. Then we can also see that I experience ableism in Asian communities. So at this intersection here, where people often dismiss and reject neurodivergence, even in their own children, because they want to save face. I also, at the same time, have a very difficult time navigating unmasking as a neurodivergent person, to unmask these neurodivergent characteristics as an Asian person too, because people already see Asian people through the lens of a model minority and see us as subservient, as quiet, or submissive. It makes it really difficult for me to unmask and not be socially active sometimes because I feel the pressure that I might be playing into that stereotype for other people when I do this. But this is just my own experience, right? And my experience can be very, very different from somebody else who is marginalized in many other ways. Let's say from somebody who is Black and autistic. They might not have the same privilege as I do to unmask. Black parents often have to prepare their children for the racism and police violence they face in this country. And part of this talk to their children, for especially if they are autistic, is the pressure to maintain that mask. And because the consequences there are so much more devastating and so much more dangerous and life-threatening, it's a very different situation. But all this is to say that people who are multiply marginalized experience oppression in very unique ways, even within these communities we should feel belonging in. And this is to say that people who are multiply marginalized, like myself, often have no true sense of safety or belonging. And that is what I mean by this is an exponential increase. So growing up with these identities, you kind of learn how to internalize this oppression and buy into that rhetoric that you are deviant and you need to conform to what society deems as normal. And when you don't, you are victimized. And because of this, I grew up learning to mask my neurodivergence, to pass as straight, and to assimilate culturally when I moved to the US. And from a young age, you could tell my mind was busy doing these things because I knew from that age the social consequences that I would face if I didn't. That would be a huge consequence. And that's why I'm going to talk about the cost of oppression here. So when you trade in your authenticity for acceptance, this actually has really long-term negative consequences. You kind of forget who you are behind that mask you create. There is a cost to internalizing this oppression. And when you mask neurodivergence, when you pass as straight, and when you acculturate or perform acculturation, these are all forms of very adaptive strategies that have helped me, right? They helped me in that moment to navigate oppressive or marginalizing environments. But at the same time, we need to consider that I needed to do this to survive. And when the choice for me and many other people is to adapt or be a victim, you don't really have a choice there. That's not a real choice. And so oftentimes these strategies involve me concealing or downplaying aspects of my identity to gain social acceptance, to avoid discrimination, or to gain access to opportunities that other people otherwise would have had. And so doing this comes at a very significant personal, psychological, and emotional cost. And when you are constantly masking your neurodivergence, it leaves you feeling burnt out. You feel anxious and depressed in the long run. You forget what your authentic self is versus the person you created yourself to be to fit in. And similarly, with passing as straight, when you're doing this, you are reinforcing to yourself that shame in being queer, that this is something so unacceptable to other people and to this culture you live in, that you have to change who you are so other people won't bully you. You're also living in constant fear that you will be outed as queer, outed as gay. And for a lot of youth, being outed also means the likelihood of being kicked out by their family, to be unhoused. There are grave consequences for this cost of oppression. Assimilating culturally, that's a similar thing. It also comes at these costs. I noticed this very apparently as I moved to the States from Taiwan. In Taiwan, I did not have to think about myself as racialized, but moving here, I am racialized as Asian, which comes with many stereotypes, especially from the model minority myth. So the model minority myth is structured in a way to make Asian people believe that we have this proximity to whiteness, which gives us certain relative privileges, right? So we are privileged in a certain sense, but we will never actually get to that. We will never actually gain access to whiteness and the power that comes with that. This myth perpetrates self-hate of your cultural heritage and often encourages the discrimination of other people of color in an attempt to assimilate yourself to whiteness. And so at the same time, when you internalize all these forms of oppression, you are often perpetrating it to other people as well and continuing this violence. So there really is a very significant cost to oppression. So it's also important to consider, how do we resist and liberate ourselves from this oppression? It's important for us to understand and have that critical consciousness of how these intersectional identities are social constructs, that we are socialized to view ourselves and others in this way. We are socialized to experience ourselves and one another as racialized. We accept this as normal, but in fact, race actually does not exist without racism and racial hierarchy. It is a social construct created to group us, to make us feel more than or less than one another, to perpetuate racist rhetoric. And we are socialized to understand disability under, so moving on to disability, we're socialized to understand disability under a medical model where we see disability as solely a product of an individual's impairment. And that is often not the whole picture, right? So if we think about this under a social relational model, so disabled people are often telling us that disability can be viewed under a social relational model. That is, that it is often, disability is often constructed and maintained because of how society functions to set up these barriers and discriminatory attitudes that exclude disabled people, that disable us by doing that. And so disability is a part of the normal human biodiversity, and that is often not acceptable to people. And so people want to treat us, to cure us, to fix us, rather than taking some time and understanding and accepting us. And when we view disability not solely as an individual problem, but also as a societal lack of accommodations or lack of acceptance, we see so many more ways that we can support disabled people and uplift disabled people. And we are also socialized to view queerness as something that is novel, it's deviant and radical, and not an aspect of the full range of human sexuality and love. And so all this is to say that when we realize that all these identities are often socially constructed, we can start to appreciate that disability, queerness, ethnocultural identity, and these are just the things I'm pulling out because I'm focusing on these things today about myself. But there are all these other amazing identities, right? These are all part of the rich range of the human experience. And by realizing that, it's something that we can start our path on to become liberated from these oppressive forces. All right, so there are a few things I want you to take away from this talk. First, people often understand privilege as a great thing, right? And it is, it gives you access and power. However, you often don't realize that you have it, and recognizing privilege can often be very difficult and very uncomfortable. And on the flip side, it is very difficult living as someone who is oppressed. But we can also find ways to liberation through resistance and ownership of these oppressed identities. And that in itself is difficult, but can be very empowering. My second takeaway is to listen to those of us who have these marginalized identities and learn from us. And at the same time, know that we do not represent everybody who has these identities. We are not the gatekeepers, nor are we the spokespeople for our identity groups. We represent one experience, and it is often a lot of pressure for people to have to speak up for themselves. But by doing that, have to also face or have to be the face of their entire identity group. We certainly don't really expect that from someone who is from a dominant group, right? So why would we do this for people who are minoritized? My third takeaway for you is that social justice is not a destination. Striving for anti-racism, for neurodiversity, to fight against homophobia and transphobia, this is not a destination you're trying to reach. It's an ongoing journey, and the field, it's often changing and generating new knowledge. We're all on this journey together, even those of us who are marginalized, and we make mistakes along the way as well. So all in all, I want you to take from the practice of one of my mentors here at UMass Boston, Dr. Karen Sugimoto. I encourage you to envision justice, to take time visioning what a socially just and better world would look like to you. And this is one way how we can lift up people who are marginalized and oppressed in different ways. Particularly, envision what do authentic and just personal relationships and solidarities look like and feel like, right, in this world that you envision. What qualities or experiences characterize this world and these relationships? And what do you want and need from other people to move, or yourself too, to move towards realizing that vision? What work do you personally need to do to contribute to realizing that vision? And for me, this means for us to build a society that accommodates, accepts, and empowers disabled people, empowers people of color, empowers queer people, people of all genders or are gendered non-conforming. We cannot build a society from our similarities, but we can build one from celebrating our differences. And I encourage you to build solidarity and show up and show out to support the people who are very different from you, who are oppressed in very different ways, no matter what your preconceived notion of their identity group might be. Because we're all marginalized in such different yet such specific ways because we live in a system that's created to divide and conquer us, to use these socialized differences to make us oppress one another. We need to end this cycle by building solidarity across different identities to come together and support each other, no matter how different that person in front of you may be. And we need this especially now. And that concludes my presentation. Thank you so much for your time and attention. And I know we have a Q&A section, but I left my email here in case anybody has any questions.
Wow, thank you so much, Josh. Thank you to Dr. Ito and Josh for your presentations. What a powerhouse duo. And I am very, very lucky to get to moderate this Q&A. Dr. Ito's talk highlighted challenges with access to care and service utilization, challenges for youth, including navigating multiple identities and family perspectives, as well as the lack of knowledgeable providers. And thank you to Josh for that thorough presentation walking us through your experience and encouraging us to not only push for not just awareness and acceptance, but also empowerment, liberation, and justice. To our audience, please submit your questions for Dr. Ito and Josh into the Q&A. And while everyone inputs their questions, I guess I'll start us off with just a couple initial questions for the two of you. Starting off for Dr. Ito, how do you use an intersectional framework when seeing your own patients or people coming into your clinic? How do you actually put this all into practice in your own work?
Thanks for the question. And first of all, Josh, that was incredible. Thank you so much for joining. Thank you for allowing me to join you on this presentation. So one of the ways that I think about using intersectionality clinically is looking at all the different pieces of identity. So like Josh was talking about, I need to gather information about all the important pieces that people feel like are a piece of their identity in order to put together. Because if I focus solely on these are struggles that trans kids face. This is struggles that Asian American kids face, or this struggle that Black kids face. It neglects how those things interact as a whole. And kids live in their communities, they live in their schools. And so I know that I have to counsel, or I do counsel maybe autistic youth with who are trans or non-binary, different than I counsel Black male teens, in terms of what are challenges, what are things that I can anticipate, what are barriers to medications, cares, all of those things. So it helps me to try to envision, all right, backing out from just the disorder, what are the different pieces of this person that I need to attend to?
And Josh, for you, right, as somebody who also interfaces with not just medical care, but are in training yourself, what would you like for providers to know about using an intersectional framework from your perspective?
Yeah, I think one thing that's really important to consider probably is that as clinicians, as physicians, diagnosticians, whatnot, it's important to not think about us as like us on one end of the table and the client and all those people at the other end of the table, right? That intersectionality is something that we all experience, and that it's something we should all try to appreciate and understand how this affects people. Yeah.
Yeah, I think so. For the two of you, I mean, feel free, whoever would like to jump in. Are there some ways that maybe we can model some of these things when maybe some of our patients don't feel comfortable, or, just showing up because we ourselves, right, are, as Josh said, it's not just like us and them on the other side of the table. But are there ways that maybe we can break down some of that stigma when these patients are showing up into clinical settings with us?
I can jump in and I can say, I think it's really opportunities and the visual representations like we talked about in different perspectives that I'm glad and honored that the forum allows me to represent. I know that when I was growing up, there were not a lot of physicians, not a lot of physicians in this space who were speaking about these things. And definitely in terms of um, graduating uh, graduating doctors, soon to be graduating doctors. I know that, Josh's perspective would have been extremely useful, not only for myself, but for the colleagues that I work with. So I think showing up as you all have is the most important.
Nice. What about you, Josh? Any other kinds of ways that maybe small ways that we can really enact and put into practice some of these things we've been talking about?
Yeah, I think that a lot of times clients don't know that these things are on the table, right? Because they feel like these are taboo subjects like race, sex, disability, but sometimes we can bring in our positionality if it's appropriate, and letting people know that this is on the table to talk about, and also following their lead about what they want to explore, how they want to explore it, and just listening and believing people. Yeah.
Absolutely, right. I think I'm pulling in pieces from Russell's talk this morning and maybe making some of those invisible pieces visible, or even just acknowledging the pieces that are visible. Right? Like both of you included some positionality statements. All of us, or the three of us right now, have our pronouns with our names. And I think gender affirming care isn't only for gender diverse individuals. Right? As somebody who has the name Jasper, I know that using my own pronouns can be very helpful when people are surprised when I walk into the door. Right? And so I think that those are some of those very visible, smaller ways, but very, very important ways to affirm gender diversity and all those other intersections when they show up to us in our clinical settings. Right? Um,
Sorry, can I
how
add
about,
to sorry to
of
interrupt.
course.
Can I add to a point that Josh also brought up and made me think about, which is, when we talk about positionality and we talk about privilege, so like Josh, I contain a number of privileged identities. So I'm a physician, I'm educated, I'm verbal, I'm male, so I can use my identities of privilege and power to help those or speak to those or for those people or give them space to speak for themselves uh, because of my identities and my privilege. So I can use it to uplift others rather than to oppress, which I think is a very important point for all of us. All of us can use our privileged identities to help others.
What about for caregivers or parents who are kind of navigating these um, multiple aspects of their child's identity, right? Their child is growing up and then maybe they're receiving a diagnosis. So there are the neurodevelopmental aspects and then exploring identity and gender, sexuality, all of those things. Any suggestions for caregivers in the audience who want to support their child in this journey?
So this is a sometimes a challenging topic, and I didn't put it in the presentation, but it's something that I run into quite frequently working with families is families may be seeking assistance or information or how to get gender affirming care. And when I meet with the child or when I meet with the family, there's other aspects like maybe, the teen also is on the spectrum or meets criteria for autism spectrum disorder. So now I'm sort of giving and delivering different aspects or identities or diagnoses, whatever we want to call them, that parents weren't necessarily prepared for. What I try to do is I try to look at it again from a strengths-based model, which is what are the benefits or what are the strengths that your child has as an individual, and how can these identities either cause some challenges or allow your child to really flourish in one way or the other. And I think a broader understanding of both and all aspects of themselves will allow for their full personality and person to come out.
And Josh, how about you in terms of navigating multiple identities? And you said that you are very lucky to have a family that supports you, but what are some maybe facilitators that would be beneficial to other parents or youth who are in the midst of navigating neurodivergence and gender and sexual identities?
Yeah, I think that's a great question. And there's so many complex kind of relationships at play, even just as being a family in general already. But I think generally letting your child know that you're willing to learn and willing to accept them, and giving them some agency through that as well and believing them. And I think a lot of times, especially for autism, understanding that every behavior that your autistic child is exuding is a form of communication. What are they communicating to you? And trying to understand that, because a lot of people often feel like autistic people, oh, they're not communicating anything to me. I don't know what to do. But actually, every type of behavior can be seen as a type of communication. Yeah, and I think also haven't talked about this a lot in my presentation, but love, just like the power of love and incorporating that into your dynamics too.
Of course. Thank you, Josh. How about supporting trans youth on the spectrum? I know this is a big question, and I cannot ignore the fact that we are in a socio-political time in history and in the context in which we exist. But maybe I'll start off with Dr. Ito. Any thoughts on how we can support trans youth who are on the spectrum?
Yeah, and I think it's similar for all youth, which is we really have to listen to their perspective. And I think one of the most important things to recognize for people out there, especially who are clinicians, is that if we have youth who are on the spectrum who are also discussing or wanting to discuss gender expansiveness or gender diversity, to not disregard that or to not minimize that as something that people cannot understand or experience, because we all experience gender in very unique ways. And so it's important that we don't negate the other depending on which seat we're in, if that makes any sense. Whenever I speak to groups, especially groups focused on neurodevelopment or focused on disability, I will always say you need to learn about gender and gender diversity because it's going to come up. Whenever I talk to the gender health colleagues, I always say you guys have to understand autism and have to understand um, how that comes into play because it will show up in your clinics. Um, and to add on to last thing to add on to your past question, which Josh brought up, the idea of love. I tell families all the time, you are your child's best advocate and supporter. And so if you are behind them 100%, really there's not much difference or there's not much disparity per se. However, if families are rejecting or if families aren't supporting their kids, their identities 100%, that's where we see a lot of the psychiatric pathology come in, whether that's depression, anxiety, suicidality. So I completely agree with Josh.
Other thoughts, Josh, to add to that?
I think a lot of times we feel like, oh, maybe I'm not a specialist in this area and I need to refer you out to a specialist. But at the same time, we are in this field and we need to learn to be with all types of clients and understand their backgrounds. And we're always learning, and that's a really important process. So we need to really try to understand what the cultural hegemony is right now and how people experience oppression because of their identities. And specific to trans youth, I think understanding that trans people, there is such a high rate of suicide, especially when people are denied care, and that trans affirming care is something that's highly, highly successful in improving so many aspects of mental health. And understanding that we need to critically challenge the way we view gender and psychopathology, because a lot of times, especially let's look at the insurance system, that people need a diagnosis of gender dysphoria in order to access affirming care. Why do we need people to feel this level of dysphoria and discomfort in order to get the care that they need? There's so many things we need to question and understand, and while we are giving these diagnoses and giving these the care to trans youth, right? And so yeah, I think there's just so many things to consider, but at the end of the day, just supporting people where they are and understanding and believing them.
Of course, right. So really affirming people however they show up, modeling that acceptance and empowerment, and really trying to advocate in all the places that we work and operate, whether it's in various clinics or in other circles, committees, all the things that we're involved in. I'm wondering, you know, thinking about Dr. Ito, your talk, and just the number of kind of like we said, double jeopardy, all of those hits and all of those challenges, and it can feel very overwhelming and such an uphill battle. Any thoughts on where to start, or what we as clinicians or people who want to do better? Any thoughts on what might be something doable, manageable?
That is a big question. I would say, again, using Josh's talk as an example, understanding the background that whiteness, straightness, um, all of those factors are generally considered as being the baseline, and that's not necessarily true for everybody. So to understand that at baseline, a number of things that we know about either disability, either treatments or evidence may be flawed because we don't have a true generalizable population that we've come to understand. I think starting off by looking at delving within the data to see where's the most disparity, or where is that happening the most, and then trying to come up and understand why is this happening. And I think if we focus on those groups that are most affected, I think it's, was it, I forget the saying, the something tide rises all boats, or I think if we focused on the most marginalized groups, that eventually will trickle up into benefit and care for everybody.
Absolutely. Right. Even, I mean, especially in the world of disability, right? Advocating for individuals with disabilities, it benefits us all. We all benefit from accommodation. So it's similarly like really working with the most impacted communities is only going to benefit the greater good anyways. Joshua, I think you were going to jump into, what were some of your thoughts?
Yeah, I think that we do have a certain level of power when you are somebody who is a physician or clinician. And a lot of times it does start from you because people respect your opinion, and you can make a lot of difference in the way people view disability or gender or race, queerness. Um, and another thing I wanted to add on is to not, assume people's problems are due to one of their oppressed identities. Let's say we have a trans client and they experience body dysmorphia. We shouldn't assume that they're experiencing this because they're feeling gender dysphoria that day. And so just like unraveling our assumptions. Another thing is really one of the things I talked about is to understand things through a social framework sometimes, that there are socially constructed, and challenging the way we view a lot of things and being open to being challenged. A lot of times I find myself the most productive and learning the most when I'm open to being challenged by other people and accepting that and saying, okay, that's right, I never thought of it in that way. And yeah, and speak to the people who are knowledgeable. And a lot of times people are very willing and really happy to support you in that.
Right. Like there are multiple perspectives. We have different lived experiences. And as both of you highlighted, those intersectionalities, they aren't a monolith, even if you identify as the same gender, race, and various identities, like we all experience life differently. So maybe one of the takeaways would also be to really show up to learn and to kind of hear from other people's perspectives. Absolutely. Any ideas? Maybe Josh, I know you're kind of jumping into the beginning of your graduate training, but ways that you're wanting to take this work or this interest, your identities into the training that you have ahead or into your future career.
Yeah, I think that it's important to me to include a social justice lens in my work because let's say I'm in a program, we're not just scientist practitioners, but we're also activists in this program. And it's important to critically consider how the ways we practice and the ways we research are constructed by Western views and how these things came about. And so again, same thing about like critically challenging that and knowing how you should change or adapt how you do it. Because the way that if people just stick to the same thing all the time, if it ain't broke, don't fix it kind of attitude, then we're never gonna go on the path to liberation.
Mhm. Of course. I think it's also important to note that like all of us are still learning, and we continue to learn. And I think especially in maybe some of the roles that we have where we are supervisors and kind of have this role as experts, it can feel uncomfortable when other people might know more than us, especially trainees, but that's okay, right? And we can welcome that and learn how to integrate that into the work that we do and the training that we do to help support the next generation of clinicians, researchers, those in the field. What about in these medical settings? So Dr. Ito, you had talked about like working with other clinics and other disciplines. Are there things that you really want to highlight to, maybe other fields or other, aspects of medicine that you're really trying to highlight to them every single time you're discussing these intersections and neurodiverse youth and gender and other identities?
Yeah, I guess the things that that I would emphasize, or I try to emphasize, is that when people experience stigma, when people experience minority stressors, whether that's discrimination, violence, prejudice, that these messages and these messages are pervasive. They're everywhere. You cannot get away from them, whether it's on the presidential debate or whether it's the news every day. And I will tell you that individuals who are affected by these are very aware. And every time we interact with media or any information that is disparaging about our identities, that takes a toll over time, and it kind of chips away kind of at our overall health or mental health. We also know from we talked about the political environment, and we know from the data that even hearing or even knowing that people are arguing about one of your identities causes worse mental health. So even if we know that there is a debate going on about gender, debate going on about who gets care and who doesn't care, if we have one of those stigmatized or minoritized identities, that affects people. And so I would say that the more we can get messaging out that counteracts that, hopefully it can reduce the amount of negative noise that people are experiencing. And then the other piece, which is family and support, is so crucial. If people have friends, colleagues, family who support them 100%, that is so protective in mental health. And so even if I can get families or get people to move just a little bit, that's both removing a little bit of stress, but also adding a little bit of protection and support. And so any place we can move that needle a little bit among our colleagues, among people we know, that could have a big influence.
Have there been, building off of that, Dr. Ito, have there been resources or things that you found to be successful in at least trying to move the needle a little bit with families?
One of the resources, especially working with trans youth, that I found helpful for families who maybe don't know anything about gender diversity, have never met somebody who identified as trans, and their only knowledge is kind of the media representations of whatever group. Sometimes being in family groups, so the oh man, I'm forgetting the names of the specific groups. I'm blanking on it. But having families sit with other families who can say, I was in your position a year ago. I was just as terrified. I was just as maybe skeptical. And since then, I have seen a complete change in my child. And these things that were issues every day are no longer there. And this is the journey that I've been to that is way more impactful than any article, data, or education that I can give. So utilizing that and as much as possible, I think can really affect families the most.
Course, right? That person-to-person connection, kind of seeing an example of what navigating these uncertain things might look like. Right, we often see that too with families of children who just get diagnosed with autism, and getting, some parent support, learning from other people's perspectives. Right? Even in our Q&A and chat today, so many wonderful comments of support to our community discussant, Katie Dungan, right? And just being able to see that representation and see that it doesn't have to be so spooky just because it's unknown or unfamiliar. Right? These are things that people live every single day. Wonderful. Any other kinds of last words, other things that we want to send off our audience with as we, kind of wrap things up for our discussion today? I know lots of things. Right? Encouraging people to utilize their voice and to take note of, upcoming election season. I think we had some resources for connecting to voting resources in our rotating slide deck. So please utilize those resources. We won't tell you what to vote for or what to do, but please do use your voice and vote for what you believe in.